we're very lucky today to have a friend and also a external speaker, Dr. Omran, whom I know for many, many years. And I was training in Montreal and Boston. I already heard about Dr. Omran's work at Toronto General. He's one of the gentlemen who first worked with Dr. Tyrone David and came up with the mitral valve mapping. So that's one of the first mitral valve mapping using TE that I learned. And subsequently, we've been sort of like using it as a base, and moving forward is continuing to do excellent work in many different areas. He's a consulting cardiologist with the Department of Anesthesia and Pain Management at Toronto General Hospital. We have the privilege today, and he's going to share with us his work in aortic valve this time. So looking forward to that.
Thank you very much, Ximeng. And so it's a great pleasure for me to be here. So let me do the next one. Yeah. So the regurgitant aortic valve repair is an art or science. And what's the role of intraoperative TE? I have no disclosure. So the objective of this talk is understand the pathology and mechanism of regurgitation in the aortic valve, review the interaction between three components of aortic valve function: effective height, geometric height, and free margin length in a competent and incompetent aortic valve, review the role of TE in scientific assessment of aortic valve, defining all the above components, helping the surgeon for appropriate repair plan and predict the durability of the repair. As Ximeng was introducing me very nicely, my job was at the beginning mainly on the mitral valve, but this couple of years I'm trying to find some type of map for aortic valve as well. So, and I'm in the OR always. So I'm cardiologist, but I'm always in the OR. So I spent about close to 40 years in the cardiac OR now. 35 years of this with Tyrone David. So everything I'm saying is a little bit like a surgical view compared to the cardiology view. But anyway, let me see how we go. So how common is the AI? AI is about 13% of all valvular heart disease, 13%. Many of these aortic valves, they are regurgitant, not stenotic. Regurgitant, they are repairable, almost above 90%. And the help is mainly from echo. It means if we define the pathology of the aortic valve before operation and tell the surgeon what is wrong, surgeon, for sure, if it's a capability, can repair it. Aortic valve is an artistic valve. That's the reason that I put the topic art or science. First was described by Leonardo da Vinci in 1513. And he described the valve that we have right now. And he described it, this diagram in your right side is a drawing of the Da Vinci, what, 500 years ago. He described the function of the sinus of Valsalva as we know these days. And this is the technology that we have today, 3D of the aortic valve. This is a surgical view. The surgeon is standing below the picture, and non-coronary clasp, right coronary clasp, left coronary clasp. So if you want to show this 3D of the aortic valve, you have to show this way that we can create a common language with the surgeon. And this is very similar to the cadaver. Aortic valve, most of the time, is tri-leaflet, but it can be bicuspid in 2% of general population, can be quadricuspid, unicuspid, different type. But most of the valve that they are regurgitant, they are either tri-leaflet or bicuspid. This is the normal aortic root. So this is nomenclature that it came like 3-4 years ago in the guideline, and we have to learn it to be able to talk with the same language as the surgeon. So aortic annulus is a virtual annulus. That's the one that we measure in the echo. Geometric height, the length of the leaflet. That's very important, because if we don't have enough geometric height, it means we don't have enough tissue, so we can't repair the valve. Coaptation height, the two leaflet, they have to coapt 4 to 5 millimeters like this. If they are coapt like an edge to edge, they will fail. So the coaptation height should be about 4 to 5 millimeters. Effective height is the distance between annulus and the tip of the leaflet. This should be above 9 millimeters. It means the aortic valve should coapt inside the aortic root a little bit higher up. If coapts exactly in the annulus, by the time it will go down to the LV and patient will develop AI. So that's the way that the aortic valve works. And as you see, it's really artistic way. It doesn't have any corda like mitral valve. It's not attached, it's not anchored to anywhere. So because it coapts high up inside the root, it can work 80, 90 years that we know. Again, this is another diagram from Schaefer that it will show this green one is the geometric height. That's very important. This blue one is the annulus or virtual annulus. That's the one that we measure in echo. And this is a closure line. As you see, the closure line has a curve. So it's like this one, this way, as a curve. And this is another diagram, the same. So these two gentlemen, they paved the way for aortic valve repair, Yakub and Dr. David. So Yakub from UK, he published the first group of the aortic valve repair in 1987. He presented it as an abstract, but he didn't publish it. He published in 1993. That's the way that he repaired the aortic valve and the aortic root dilatation. This is the way that Dr. David did it. So Dr. David reimplanted, it means he took the aortic valve, reimplanted inside the dacron. As you see, the dacron goes outside. Here, the dacron goes as an interdigit. So the way that David did it, it will keep the aortic annulus intact, doesn't allow it to dilate. But the way that Yakub did it, the annulus might dilate. So, but Yakub created the sinus of Valsalva. In David operation, there is no sinus of Valsalva. So the drawback of this operation is no sinus of Valsalva. We know the sinus of Valsalva has a great role during the diastole. This one has a sinus of Valsalva, but annulus might dilate. So for sure, this operation is not good for Marfan patient. And this operation, because there's no sinus of Valsalva, it might fail, but did not fail. Because Tyrone has a follow-up of 27 years, he published, and 29 years, I saw a patient a couple of weeks ago that Tyrone did a valve sparing 29 years ago, and it still is okay. So that's very long term. So I was very lucky that I became fellow in this year, exactly the time that he published the first group, 10 cases of valve sparing. So from that time, I was involved most of the time. These two gentlemen, Tyrone and Yakub, he's retired now from UK, they did based on the art. So they look at the valve, they repaired it. There's no measurement. But for every type of surgical work in cardiology, we have to create a science. We have to do a measurement to make it reproducible, that somebody else can do it. So science came later, the measurement. So what we should measure and who should measure it? Surgeon or echocardiographer? I believe the echocardiographer should be able to measure everything that surgeon can measure it and tell the surgeon in advance the information. The surgeon can make a decision, or even the day before. Surgeon can say, okay, based on the measurement that echocardiographer did it, your valve is repairable, okay? The first surgeon that started to measure something in aortic valve is Al-Khouri. So Al-Khouri is a very famous name. He used to work in St. Luke Hospital in Belgium. I think he retired a couple of months ago. And he was a fellow of Tyrone David, same time I was fellow. So we were together. So this is the Al-Khouri classification for aortic root, 1A, 1B, 1C, and type 2, type 3, exactly as the way that Carpenter did it for mitral valve. And then he started to measure the free margin lengths. He's doing now to free margin lengths, and we can do it by echo as well. The problem is when we want to measure the free margin lengths, if we use 2D, we measure from here to here, but this is not the real. The real length is this one, this curve. So if we use a 3D and MPR, we might be able to measure the same way, but still we are lacking, at least based on the number of cases that I did. We underestimate the actual free margin lengths. You might ask me, what's the role of measuring the free margin lengths? It's very important because the 3 leaflet, they don't have same size free margin lengths. The right is longer usually, the 2 other are shorter, and the left is the shortest one. So right is the longest one, and the left is shortest one. That's the reason that the right has a more common to have a prolapse, and the left is the least common to have a prolapse. Okay, so we underestimate about 4 to 5 millimeters so far, but I'm trying to come up with some way to do it exactly as the surgeon can measure. So this is, again, David operation that we call it aortic root reimplantation, aortic valve reimplantation. And this is a way that we make a diagnosis of the prolapse. So this is a right coronary cast prolapse. As you see, this is a complete prolapse, and this is like a partial prolapse. So when we talk about the measurement, we need some instrument. I don't think there's any surgeon here, but we need an instrument to measure. So this is one of the instruments that's called Schaefer Clipper. This was developed by Dr. Schaefer, another very famous aortic valve repair person from Hamburg. And that's the way that he measured the effective height, the caliber. And this is the roller. At the beginning, it was just a regular roller. Now he developed this one. And so this is all the tools that we should have it in the OR when we try to repair the aortic valve. This is one of the latest paper of the Schaefer, that how he repaired it. And he believed that any time that the sinus of Valsalva is dilated more than 42 or STJ is more than 35, we should bring it down. And there's a question that if the leaflet has a fenestration, is contraindication for repair? If it's a small fenestration, no, because a small fenestration is very common, but if it's a large fenestration, might be a contraindication. So what we should measure and how we measure. The main thing is we should measure the effective height, that is easy by echo. We should measure the geometric height of the leaflet. Geometric height of the leaflet, we have a software now in the echo machine that I'm sure many of you use it. There is a button in the echo machine. The machine that we use it is mainly Epic. It's called multi-view. It's a very useful software, and we use this multi-view to measure the geometric height. Based on the geometric height that we measure, we can predict the size of the dacron that the surgeon can use it. So we measure the height of each leaflet and take an average of this, give 4 to 5 millimeters for coaptation, and the rest will be the size of the dacron. Size of the dacron tube is very important in David operation, because if you put a bigger size, you will have a gap at the middle, you will have AI. If you use a small size, the valve will be squeezed and will be billowing down to the LV. So you will have AI. So that measurement, the surgeon can do the measurement as well, but we can do it before for the surgeon. If the leaflet length, geometric height is not enough, less than 1.6 or 1.8 millimeter, that valve is retracted and is not good to be preserved. Even the time that I was with Dr. David, in that time, like in 94, we tried to come up with some type of formula to size the dacron. This was a very, very long mathematical formula. This type of formula, I'm sure that Shaving like it because he's an engineer. So gradually we found out this is a very complicated formula, and we use our way to measure by the multi-view. So if the dacron is small, the valve might drop down like this, billowing, and we have to do more application of the leaflet or put a bigger size dacron to not having the billowing. So I will show you 4 or 5 cases from our center to see how this measurement works. I tried to finish it earlier and keep some time for questions. So this is one of the tri-leaflet valve, as you see. This is the X-plane in 3D. You can put the X-plane at the middle or center of the right clasp. Patient has a severe AI, central AI, and so this is severe AI. Sinus of Valsalva is dilated, STJ is dilated. Okay, that's a severe AI by any of our echo measurement. I'm trying to measure now the geometric height. First, I use the X-plane. I put the line at the middle of the right clasp, and I measure the length of the right clasp. So if you are not at the center of the right clasp, your measurement is not accurate, because as you know, all city clasps, they are crescent shape or semi-lunar. So if you're not cutting at the middle, you will underestimate. If you cut it oblique, you will overestimate it. You have to be sure that you are measuring, you are cutting at the middle center of the leaflet. So this is a right clasp, so it's good. And for other one, you take a 3D zoom of the aortic root in short axis. Make sure you get it in a 1-bit acquisition, not multi-bit. If you take it multi-bit, you will mix the measurement. 1 bit. Okay? And then you press this button. You have this. So you put this red axis at the middle of 1 by 1. Now I'm at the middle of the non-clasp. And so I'm sorry, let me go back. So I'm at the middle of the non-clasp, and I measure 2.04 here. Okay. Then I put it at the middle of the right clasp. Again, middle and perpendicular. And I got the right, it became 1.89. Then I put at the middle of the left. I expect left to be smaller. Left is always smaller, but left has a problem. The left corner clasp is a blind spot of our TE probe because there's a bending there. So we always underestimate the left clasp. We should measure 2-3 times to be sure. But we know that left clasp is smaller. So again, this diagram shows that we should measure in a green way. You see, we are at the center of this crescent shape. Not this way, because we underestimated, and not this way, we overestimated. So if we don't use the multi-view, we either underestimate or overestimate. So we should be at the middle. For free margin lengths, I measured here in a 2D only, and I know that I underestimate about 5 millimeter. Okay, I use many times in NPR, still we are underestimating, and I'm trying to solve this problem. So this was my finding, and this is surgical finding. It means except the left corner clasp, very close to the surgical finding. Surgeon measured it like a millimeter, is not even millimeter difference. So very accurate measurement. For left clasp, I measured 1.44, and the surgeon measured 1.7, and we know. So my measurement came that the dacron should be 30, and the surgeon put 32. So one size bigger or smaller doesn't make a big difference. Post-op. This is the, so again, this David operation. This is not due to David himself, because we have now 3 surgeons they are doing in our center. So this is the valve. That's a very good effective height, very good coaptation height. This is the virtual annulus. No AI at all. So like imagine. So 0 AI. Case number 2, this is a bicuspid. So the initial David operation was described for tri-leaflet valve. Gradually, he used to do it in bicuspid as well, and now he do it bicuspid, tricuspid. And as I said, 2 other surgeons are doing in our center. This is a bicuspid valve. So you see the bicuspid, right clasp and left clasp fusion. This is a very common form of bicuspid or Siever's classification. Usually the right has a prolapse. That's the reason that they will have an AI. So it's a severe AI. See here. So these are all cutting of the surgeon in the OR. You know, we have a complete business surgeon in the OR. Is a severe AI. And this is the annulus, sinus of Valsalva. This angle is very important. We should measure it in the OR. We call it commissural angle. We measure it from in a close position. We put a dot in the center of the circle and take a. This measurement is in our echo machine. So if you do go to the echo machine, the Philips one, there is a item is called tools. When you go to tools, it's called generic angle. You can measure this angle. If this angle is less than is more than 160 to 180 is very good. 160 to 140, not very bad. Less than 140, it means the valve is very asymmetric, and usually if you repair it, it will be stenotic. That angle is very important. Like this, you see, this is the angle. So this is a fusion between right and left, and this is the angle. So it's above 1.60, it's good, like this case. And we measure the lengths again. We can measure the same with, again, with the multi-view. Here, in bicuspid valve, we can measure only the geometric height of the non-fused one. And again, the non-fused one should be above 1.9 in bicuspid valve. So we measured here 2.4. So we gave a green light to the surgeon that valve can be preserved. And she is another surgeon. She preserved it. And you see the post-op. So she has to bring the annulus down below 2.5. So anytime we do a valve repair, we have to bring the annulus down to 2.5. Okay? So he brought it to 2.5, and you see the valve. Again, no AI at all. So that's a very good result. This is Dr. Chang from our center. Very nice result. And in pre-discharge echo, I'm just going to show you something here. That's a pre-discharge echo. Look at how the valve open and close. If you show me this valve, without knowing the history, I can say this patient had a delayed operation. Because the valve, instead of opening slowly and closing slowly, opens abruptly. See, quickly. That's a way that shows this patient had a delayed operation. Because there's no sinus of Valsalva. See, collapse like this quickly. Our native valve collapse slowly because we have a sinus of Valsalva. This one we don't have it. And no IR. Case number 3 is another case of bicuspid. So this is not a good valve to be repaired. You see, this is a bicuspid, but the valve is very asymmetric. If I measure this angle, see, is it like this? It's 118. This case was done just last week. And this is an example of the valve that cannot be repaired, should be replaced. And this is from diagram from Al-Khoury group again. This is type C valve with sharp angle that cannot be repaired. And this is pathology we just did a couple of days ago. You see, this is the large cusp and a small cusp. The case number 4 is another tri-leaflet valve, but the leaflet is retracted. You see, I measured the leaflet. Severe AI. So if I measure the leaflet geometric height, came only 0.9. See, I measured here. So I told the surgeon that this valve cannot be preserved. This is Dr. David himself, and he replaced it. So you can tell exactly what you have to be sure that you are sure, because the surgeon might measure and you might be wrong. So this is the last case, known history of AI. So as I started at the beginning, aortic valve repair is an art or science. Is an art for a senior surgeon like Dr. David. Is a science for us that we have to learn. So this is Dr. David's case, and I did all measurement. We didn't look at measurement at all. Just look at it and say, I want to repair it. You see it, severe AI. That's a severe prolapse of the right cusp. And see, severe AI. And post-op, did the David operation. Again, no AI. Very good geometric height, very good effective height. And this is a pre-discharge echo. Okay. So you might ask me, any AI case can be repaired? I would say about 90% of time, yes, in trileaflet, and above 70% bicuspid valve. 90% trileaflet, 70%. There is three challenging. One is the retraction. The leaflet is too short, cannot be repaired. Any tissue in anywhere in the body, if it's not enough, you cannot create it. Okay. So retraction is contraindication. Retraction means the length of the leaflet is less than 1.8 or 1.6 in trileaflet, less than 1.9 in bicuspid. Calcification, you might take it out, but again, some surgeons believe that we should not repair the valve is calcified. Fenestration is not contraindication if the surgeon knows how to repair the fenestration. So this is one of the Dr. David's last paper, 2023, and he showed in 404 patients that he did for 27 years follow-up, 40 of them, they had a severe AI, and only 4.7% they had a redo in 27 years, okay? And this is a very good two paper for echo people, especially for our fellows, that they showed the way that I am doing. So not all of this I'm doing it because I didn't publish. They're at like 2019. We do now more than this. So there's a paper from Berrabi and Al-Khoury, from Al-Khoury and Dr. David, his last. These two papers are an echo paper. One is from Dr. Berrabi and Emmanuel Lansek from Paris, and he's my friend. He's a cardiologist in the OR all the time. And one is from Dr. Hagendorf from Germany, Leipzig, and with Schaefer. These two papers, they show the way that I showed you, but mine is a little bit more detailed. So in summary, trileaflet aortic valve morphology accounts for 60%, and rest are bicuspid. The art of successful aortic valve repair can be learned and completed by scientific and reproducible measurement in pre-op TE, intra-op assessment by surgeon, and observe many repair by surgeon. Intra-op TE plays a major role in defining the morphology of the valve, mechanism of the AI, and providing a map to guide the repair. Post-op TE can evaluate the immediate result and determine the predictor of repair durability. It's very important to have a good effective height post-op to have a durable repair. You can have 100% result in the OR, but you needed more than at least 10 years for a good outcome. So perfection is not attainable, but if we chase perfection, we can catch the excellence. Probably these are excellence, not perfection. And this is Dr. David and me in October. I'm happy that he's working and I'm still with him. I think we should be retired together because we're working for 32 years now. And thank you very much. And I take
So these are like the dream team that we have known in Toronto. So I think during my training, I'd heard about this dream team and I kept running into all their work. So I don't know if there are enough sonographers around here, but when I first arrived here on the echo machine that we push down to the intraoperative TE, we used to do them. And there's always a card with Dr. Omran's diagram with the mitral valve mapping.
Yeah.
So we used to have to cheat. It's like, yeah, is that A1, P1, A2, P2, A3, P3. So that's where it came from. So yeah, we do have a legend with us today. So we're really privileged. And I always want to know what is it like to work with Dr. David. But that's maybe beyond this discussion.
I can work with him. Probably I am the only person that can survive with him. Yeah. Yeah.
These godlike figures in our history.
Yeah.
So this is wonderful. And like how much do your surgeon actually listen to you? That's actually what I'm wondering about, because you are very accurate, as you have demonstrated. and they will use their own instrument to measure. So often when we're doing intraoperative TE guidance, then you say, okay, so how much do they actually listen to?
They listen, especially when they see they measure the same. Well, they listen. But again, it doesn't mean we are 20 in the OR right now, mainly the anesthetist. I'm the only cardiologist with them. If I do it myself, they listen to me. If I don't do it, because this measurement is very, very difficult to measure. But usually they listen, and I ask them most of the time to measure by the instrument themselves to see how I'm doing, and I've watched them also. So all of this repair that you see it, I'm there. So I learn from them, and they learn from me. That's right. No, they listen. Yeah.
And how much do you use it before the operation to plan on the surgical approach?
No, we don't do TE pre-op, but because as you know, our echo level is separate from our OR. So we are the OR team that we are from anesthesia department. Most of them, they don't have pre-op TE in our hospital, almost close to 100%. So they have echo outside. We know that they have AI. We know that they have a dilated aortic root. They come to the OR and we do pre-op there. So no, they don't have pre-op TE for aortic valve. For mitral, many of them they have it, and mitral now is easier. For aortic, mainly we make a decision indoor.
Yeah, because I thought with your prediction, then you can actually prepare whether you're going to repair this versus replacing it.
Yeah, but usually most of our surgeons, they write in their chart that we look at it in the OR and make a decision is repairable or not. But we know that most of them can be repaired. Yeah, if it's not a stenosis. A stenosis is.
Yeah.
Yeah.
So maybe you could tell us, what does a surgeon actually do? So I've seen some of your images, they plicate.
Yeah.
But that can't be the only thing they do.
For the lift, yeah.
What are the options for them to repair?
So the aortic valve repair and preserving has a two parts. One is repairing the actual leaflet. So any leaflet that is more than 5 millimeters longer than other leaflet should be plicated. 5. So we plicated, make them same lengths. Okay. Then if there is a fenestration, we might close it or we might patch it. So if there is a fenestration in the free margin, they put a Gore-Tex reinforcement, the free margin, and stretch it to make it straight. Okay. They might do subcommissural plication to bring the valve a little bit higher if it's a prolapsing. So this is on the valve. So plication, Gore-Tex reinforcement, and closure of the fenestration. This is on the valve itself. Okay, but in the root, we have to give them the size of the dacron. But somebody like David, he look at the patient and just make a decision. Okay, and then just put the dacron outside. The difficult is to repair the leaflet itself, and then any repair should be secure. It means if you repair the aortic valve alone, it will fail next week because there's no support. The support is you have to do either aortic annuloplasty from outside by a suture, or put a dacron outside as a David operation to keep the repair. Otherwise, it will fail. So we have to keep the annulus below 25 and keep the STJ below 35. And that dacron is 32 or 34, we'll keep it. That's it.
So most of them get a dacron graft.
Yeah, at least in our center, all of them, most of them, they will get the dacron because it's a David operation. In our center is David operation. Some centers, they use Valsalva graft. That's not a straight graft. As like a sinus of Valsalva. It's made by company. Our center, we don't use it because we believe this Valsalva graft is circular and our aortic root is cylindric. So we should not use this Valsalva. So yeah, most of them in our center, because it's David operation, and our other surgeon, they do the same. It's a school of Dr. David. So they all put the dacron outside. Yeah.
So most of these patients are young?
Oh, no, now they can be any age. Young, for sure we should do it. But in young, we have another option. That's a Ross option, Ross operation.
Right.
So If you doubt that you might not be able to repair it and patient is 30, just do a Ross operation. It's very common now in our center. And Ross has another 30 years follow-up. So, but in older, we do it at least up to 65, even 70, we do it. Because
But calcification's a problem.
yeah, calcification problem. So if it's a pure regurgitation, if it's a pure regurgitation, this 13%, 14% I showed, they are pure regurgitation. If it's a pure regurgitation, there's no age limit, because when we repair it, if we expect this patient will be alive another 20, 25 years, it's okay. If it's not, we might do a TAVI inside that, because you can put a TAVI inside. Yeah.
So can you comment on the structural valves, like J valves for aortic insufficiency?
So I know this J valve now is good for AI, but no, I don't have any experience myself, because again, we are separate. They're separate from the structure.
Separate group.
Yeah.
And artificial intelligence in measuring these things?
No, I like to hear from you. So we have to use it. These measurements are new.
Yeah.
I don't know we can use it, artificial intelligence to measure. It would be very good, especially for free margin.
Yeah, these are hard.
Yeah, because in free margin, still we are a little bit, we cannot do it very accurately. And I asked the surgeon to measure it. We have to see the way that they measure it, they stretch the leaflet and measure it by a suture. And the way that we measure it, maybe we are not stretching enough. We are always underestimated. But we have to find a way. Yeah.
So I have two questions.
Yeah.
First of all, we are honored to have you here, and it was a day that we are waiting for. So my question, maybe I missed that, but when they repair the bicuspid aortic valve, do they preserve it as bicuspid?
Yeah, that's a very good question. We don't try to divert or revert the bicuspid as a tricuspid. Okay? So we have to make it a good bicuspid. Good bicuspid, it means symmetric, two commissures symmetric, 180, 180. But you might say any bicuspid valve by default is a sternotomy, because bicuspid opening ovoid shape, trileaflet opens triangle. Any triangle is bigger than ovoid shape, ellipse. So we have to make it good bicuspid. It means we don't open the raphe to make a trileaflet. If you open the raphe, looks like you made it good, you made a trileaflet. But there's no commissure below that raphe. So the valve, the part that you open, it will drop down. So there's no way to make a trileaflet. We make it a good bicuspid. It means we close the raphe more, correct any prolapse, make it exactly the same length. Make it a good bicuspid. But if this bicuspid is not, is very asymmetric, you might make it a very good ovoid shape, but this good ovoid shape will not be at the middle of the circle. It will be one corner of the circle. So it will be a stenotic. That's the reason that anytime valve is very asymmetric, you can repair it, but you will have an AS post-op.
Because when I saw the picture, when it's open, I thought it's bicuspid. I said, did they repair it? How still? So it is bicuspid. Yeah. My second question is, did you hear about this when they do tricuspid leaflet from the pericardium?
Oh yeah, Ozaki.
Yeah.
So Ozaki operation is not approved in North America because they use any foreign tissue you use to augment the aortic leaflet. It does not work so far. It does not work. They use pericardial tissue to create or to construct a new aortic valve. That's called Ozaki operation. Ozaki is from Japan. He did himself about 700 patients. He presented everywhere, but nobody in North America approved it. So it's not approved, but you can do it. He has a good result himself. Okay. And some people recently, last year, they showed it in one of these AATS. They used the aortic wall to augment the leaflet. Again, does not work because aortic wall is 2 to 4 millimeters thickness, and our leaflet is 1 to 2 millimeters thickness. So it will calcify. So, and they use core matrix, the new synthetic patch. Again, does not work. That's the reason that when you have a retracted leaflet, there's no solution so far. but we have to create some synthetic material to replace the leaflet that is retracted, is short, or is frustrated, or is bitten by enterocolitis, for example. So far, there's no solution. Yep.
Yeah, thank you. Does the Dacron sit above the coronaries? I assume it.
No, we do reimplantation of the coronary.
Oh,
So
okay.
the valve will go inside the Dacron. The three commissure of the valve will be sutured to the body of the Dacron, okay? And the two coronary will be reimplanted. So aortic root replacement, doesn't matter you do a Jacob operation or David operation, you have to reimplant the coronary. Reimplantation of the coronary, like 30 years ago, 40 years ago, was a little bit challenging. Sometimes osteostenosis these days is very simple. And lots of even pediatric surgeons, they do it because they do valve switch operation, pediatric. They are very good in reimplant.
So we have Dr. Parker on. So I think one of your former colleagues at UHN.
Okay.
Now we're assessing mics. So Tom, you want to make a comment or?
Yeah, thanks, Chimeng. So first of all, Ahmad, thanks very much for a talk. It was outstanding. Really nice to see you again. It was nice to think back on those days in the early 90s back at Toronto General. I have a question, and maybe you've already answered it, but occasionally we see asymmetric tri-leaflet valves with one small leaflet and AI. If the small leaflet length is really small, are those valves harder to repair or are they not repairable?
Yeah. First of all, if the valve is asymmetric, we try to keep it as it is. It means when we implant it inside the coronary and three commissure are not symmetric, we implant it as asymmetric as it was before. We don't try to make it symmetric because one of the valve will be stretched, one of the leaflet, and another will prolapse. This is the first. But if one of the leaflet is short, as you see it in my case number 4, I think, the right was short. The left and the none were okay, but we replaced that valve. So any leaflet that is short below 1.6, we should replace that valve. We cannot preserve it. The reason is this. If you have a short 1.6, that 1.6 needs 4 to 5 millimeter to co-opt. It means you have 12 millimeter left. It means you can use Gore-Tex 24 only to bring these 12 together. And if you put the Dacron, if you put the Dacron 24, patient will have a severe AS in ascending aorta. So anytime any leaflet is below 1.6 is a contraindication.
Thanks for that.
You're welcome.
I have a question.
I think there's questions from.
There might
Okay.
as well.
I have a question.
Okay, so go ahead.
I'm not trying to put us out of business, but can we have the measurement from the CT?
Yeah, that's a good question. There is one center in Cleveland, because I talked with them. They do this CT before they come to the OR. Okay, yeah, we can have it. But this CT cannot, you have to use the dynamic CT, cannot measure the leaflet as it opens close, as we do it in echo. So probably echo is better than CT, but you can do initial measurement by CT before you come to the OR, have some idea. But the actual measurement, probably in echo, yes, we don't want to be out of our business. So it's a dynamic. Echo is the most dynamic imaging that we have in the world. So we don't want to lose it. Yeah, yeah, it can be done by CT as well.
You don't know. Yesterday they did 4 cases with ice. I was doing nothing. I was just
Anyway.
So yeah.
And Amin, thank you for joining us again. And question in Canada, how many centers can do aortic valve or aortic regurgitation repair with good result long term?
Yes, that's a very good question. In North America, about 10% of centers that can do aortic valve repair, entire North America. So also the David operation and Jacob operation were introduced in 92, 93. It still is not picking in every center because it's very demanding. It's not easy. So repair of the valve is easy, just application, but keep it as it is inside the Dacron. The way, don't twist the valve is not easy. So 10% of all centers in North America, they are doing. In Canada, I don't think too many centers. In an area that we are now, I think all cases will come to our center because you need a good volume as well. So you have to do above 20 per year to be expert. We are doing about 15 our center per year. So above 20, like in mitral, you have to do about 50 to be expert. 20 is many centers, they don't have this number. So as I know around, nobody's doing.
So in Ontario, how many centers are doing it, and how do you refer patients to you? What's the waiting time?
No, it's not long waiting time because we have 3 surgeons are doing now. So in Ontario, yeah, as I said, as I'm aware, nobody's doing in Hamilton, not in London, not in here. I don't think anybody is doing except our center. I don't know here, you're doing?
No.
No. But I think if you refer the case to our center, our division head now is Dr. Maral Ozonian. She's doing herself. And we have a aortic valve center in our hospital. If you refer it, I don't think waiting list is too long.
Thank you. Thank you.
No, we're very lucky to be in Toronto. I think being in Canada, we have our group of talented surgeons, and they are highly concentrated. You have to be very talented in these kind of surgery, as I find out over the years. And some are born with it, and some we struggle to learn in our whole life. So any other questions? Without that, I just want to thank Dr. Omran. He's a great friend. We've known one another for a long time. Come and visit us again. And